Radhesh. Dr. Radhesh is the radiologist for the last what 23 plus 11, 34 years, and he's a trailblazer and an exceptionally good radiologist. The many characteristics that I know of him is one of them is you give him a problem, he will go to the end of the earth to find the solution as a radiologist, which is a great trait. So he will give you the answers to the questions that you ask of him. So the important thing for all of us to understand is you need to communicate with them as to what the clinical suspicion is, what the history is properly, so that they can then tailor their investigations according to the need of the patient and give you the answer as well as they possibly can. I think MR scan has come a long way in solving many of the problems, and the MR scan is a good friend of surgeons, both general, hepatobiliary, and even orthopedic surgeons, musculoskeletal, of course, neurosurgeon as well. So, Dr. Radesh is amongst many things he has trained with the pioneers of MR scan in the United States. I think he did a clinical attachment for a significant period of time there. So he will be able to talk to us about the role of MR as far as surgery is concerned. Over to you, Radesh. Thank you. Thank you for accepting our invitation.
Yeah, thank you, Ravi. Thank you so much. In fact, Ravi and I have been schoolmates, have been college mates, and we share a wonderful relationship. And thank you, Ravi. And you are a wonderful human being. Surgery apart, you're excellent. So, what I will be doing today is let us have an interactive session, and I'll be telling you the basics of MR, what MR is, and what are the basic sequences that you use. Now you get confused between T1, what is T2, what is inversion recovery, what is diffusion weighted. There are too many terms in MR, but let us try to simplify it in the first 10 minutes. After that, let's look at MR. What are the indications for MR? What are the advantages of MR? And I will be showing you the normal anatomy of liver today, and we will also look at few very common conditions on MR. And let's have a very interactive session. Please, you can interrupt me in between as many times as you want. Okay, don't hold back the questions till the end, because then we'll say that Zoom meeting is over, 1 hour is gone, so I did not get my answers. So let's have an interactive session. And thanks to Ravi again for bringing out a very, very, very important point here. It is always the clinical history. And though I am a radiologist, I always say in my lectures, it is patient first, image next. Okay, it's always clinical. Even I look at the patients first before even looking at the MR or the CT images. So that is so important to know the patient in depth. So with this, let me start off with my presentation. I'll just share the screen for you. Please let me know if it is visible.
Yes, Radho, it is visible.
Yeah, okay. Okay. So for those who haven't seen an MR, let us start off as to how an MR looks like. This is called the gantry, and this is the bore of the magnet where the patient goes in. This is the table. The patient goes in to the bore of the magnet. Now, the moment patient goes into the bore of the magnet, what happens? And how do we get an image? If you take the human body, 90% of the human body is water. And what is water? Water is H2O, meaning you have hydrogen protons, you have oxygen. Now, when the human body or the patient goes into the gantry, here inside the bore, what happens is the hydrogen protons which are there within the human body, they start aligning along the magnetic field. The magnetic field is at the entry of the magnet here all the way to the back of the tunnel. So that is how the magnetic field is aligned, or we also call it as the Z axis. Now, when the patient is in the magnet and the protons are aligned along the external magnetic field, we give an impulse known as the radio frequency pulse. You're all aware of the RF pulses. Your mobile, in fact, works on an RF pulse or the radio frequency pulse. So, how much of RF pulse should I give for me to get an image? Now, if the precision frequency, I'll just start bringing in terms, but I'll make it extremely simple, and you can always interrupt me. When the hydrogen protons are there within the magnet, they're not still, they're always precessing. I'll just take this pen. So there are two movements of the hydrogen protons which happen. One, it spins on its own axis, which like a top. The top is spinning on its own axis, and then it also wobbles. It goes around. So there are two things happening. One is spin, the other is precision within the magnet. Now, what is the quantum of spin? What is the quantum of precision? Is calculated by the magnet. We need not do anything. The moment the patient lies in, let it be a pediatric case, let it be an adult case, it will automatically calculate what the precision is, and this is known as the Larmor frequency. Now, depending on how much the precision is, so much of RF pulses go into the magnet and hit the protons within the human body. Now, let's recap in 1 minute again. This is the magnet. This is the bore of the magnet. The magnetic field extends from the entry to the end of the tunnel. When a patient is positioned within the tunnel, the hydrogen protons align along the magnetic field. These hydrogen protons are not still, they are spinning, they are precessing, what is known as the Larmor frequency. And depending on that frequency, the quantum of the radio frequency pulse which hits these protons is decided by the magnet, not by us. The magnet itself decides automatically and gives a radio frequency pulse. Is it clear till now?
Yes, yes.
Good.
Very clear.
Yes, sir.
So now, what happens when the radio frequency pulse hits the hydrogen proton? The proton gets energy, and this energy, what the proton gets, helps it to tip to the horizontal plane. So it will be aligned along the external magnetic field. The moment I bombard this hydrogen proton with radio frequency, it flips into the horizontal plane. Now, what happens? Once it flips into the horizontal plane, we always know anything which absorbs energy has to give back the energy to the surrounding medium. So this hydrogen proton, which has acquired the energy, that is the radio frequency pulse, and tipped to the horizontal, starts giving out energy to the surrounding atmosphere or the surrounding area, and it starts coming back to its normal position. Now, if you look at the figure, the hydrogen proton is here, the radio frequency has tipped it to the horizontal plane, and I take out the RF. I don't bombard, I bombard it with RF, radio frequency, and take out the radio frequency. So the hydrogen proton gives the energy back to the surrounding area and starts coming back to its equilibrium point. At this stage, what I do, there is an antenna here within the magnet which picks up these signals when it is giving out the energy to the surrounding area. It could be to the amino acids, or it could be to the surrounding fat, it could be to the surrounding marrow. So this antenna which is there in the MR picks up these signals, and these signals are then sent to the computer where a complex mathematical analysis takes place, what we call it as the Fourier transform, meaning the signal which the antenna receives is converted into a mathematical equation, which in turn the computer assigns a gray shade to each of the points. Now, this is the signal coming out, antenna is picking up, putting it to the computer transforms it into shades of gray, and that is how you get an image. So it may look simple, but actually it's extremely complex. So again, a recap in 1 minute: magnet, bore, magnetic field from the front to the back, patient who is lying inside the magnet, the hydrogen protons are aligned along the magnetic field. The radio frequency pulse given to the hydrogen proton flips it to the horizontal plane. So this hydrogen proton cannot remain in the excited state. It has to give out the energy to the surrounding amino acids, proteins, fat, muscle, and so on. And then it starts coming back to its equilibrium. During this stage, that signal, when it is losing the signal, the antenna picks up the lost signal, puts it into the computer transforms the signal into a gray-scale image. This is how you get an image in MR. Let it be brain, spine, abdomen, MRCP, MR urography. That is how you get this signal. Clear?
Very clear.
Okay. Now, let's go to the advantages of MR. There is no radiation in MR. What radiation is not there? The X-ray radiation is not there. Please remember, your radio frequency, your mobile, okay, there is some amount of radio frequency which is there, which makes the mobile work. In fact, if you take this mobile into the MR room and you close all the door, your mobile does not work because there is a cage surrounding the magnet. This entire thing is a cage, radio frequency cage, which does not allow external RF to come in. So your MR has radio frequency. That is why we do not bombard these patients continuously with a radio frequency. Now, there are no reports, at least as of now, what may happen to the patients who have undergone MR frequently. Unlike CT, CT does have X-ray radiation, so MR does not have X-ray radiation, but it does have some amount of radio frequency which you absorb when you are within the magnet, but this is all within described limits. Because if it exceeds that limit, what we call as the SAR, SAR, surface absorption ratio, the machine stops working. So the moment your SAR limit goes up, the machine stops. Then multiplanar and cine imaging is possible. What is multiplanar? Initially with CT, we could get only axial sections. Then came reconstruction in coronal and sagittal planes or oblique planes. But the beauty of MR is you can acquire the data in whatever plane you want. It can be axial, it can be coronal, sagittal, single oblique, double oblique projections. For cardiac acquisition, we use a double oblique projection. So you can do whatever plane you want to on MR. Cine imaging is possible. Cine, we run it like a movie. In this talk, I'll also show you a case with cine imaging, where you can see like systole and diastole. Excellent soft tissue resolution. Now, why is the soft tissue resolution in MR so good, but in CT it is poor? The advantage of MR is it detects what is the number of hydrogen protons in the tissue you are imaging. So that tissue may contain fat, it may contain muscle, it may contain cortical bone, it may contain marrow, or it may contain soft tissue like liver, spleen, pancreas, and so on. But each of these structures will have a different amount of hydrogen proton within, say, 1 pixel. Now, 1 pixel of pancreas may have 100 hydrogen protons. Okay, I'm just giving you an example. Liver may have 80, spleen may have 120. Okay, so this detects the number of hydrogen protons, and that is what determines the signal, which are so different for each of the tissues. Now, better spatial resolution. What is spatial resolution? Now you want to see, say, the pancreas, then you want to see the pancreatic duct, you want to see the peripancreatic tissue. Okay, so this MR gives you a better spatial resolution, meaning what is there between these, that is the distance between one structure and the other can be clearly demarcated by MR by using different sequences. That is what you mean by spatial resolution. That is the difference in signal intensity over space. That is over the distance what you are imaging. Then different signals from different tissues from different sequences. I tell you, MR is the most because I always say in my talks to the radiology postgraduates, I say the more MR I read, the more I realize how less I know. I tell you, this is the truth. The more and more MR you go into, you realize how less and less you know. That is the beauty of MR. It always keeps you thinking. It always makes you read because of these sequences. Different sequences. It could be T1. I'll be showing you only T1, T2 diffusion, inversion, recovery. 3 or 4 which you need in your day-to-day practice when you put up the MR images on your monitor or on the film, on the view box, you need to know only these sequences. So remember, different signals come out of different tissues by using different sequences. Now, what are the contraindications for MR? The contraindications are, before you send the patient for MR, you have to ensure these patients do not have a pacemaker. But I would like to say we were one of the first to do a study on MR with pacemakers. And it is not far off that patients with pacemakers can be imaged with MR. In fact, we have recently done 2 cases with pacemaker. Only thing here is the pacemaker should be MR compatible. And it is always better that there is a technician because we don't want this pacemaker to behave differently once they get into the magnet. So that is why, though it is MR compatible, we always have a technician by the side. Okay. Then neurostimulators again are a contraindication, which you should not send these patients for MR. As of now, think of 2 things, pacemaker and neurostimulator. So there are 2 hearts. One is the heart in the thorax and one the heart in the brain. Okay, do not send these patients for MR. Sternal wires and prosthetic valves are not contraindications. Okay, if the patient is a sternal wire. And most of the cases, like when the consultant calls, he says he has implant, there is a hip implant or a hip prosthesis, or there is a rod in the femur. Can you do an MR? These are all not contraindications. Remember, any structure which is put into the body cannot be a ferromagnetic substance because you cannot use a ferromagnetic substance inside a human body. So all these become compatible for MR. You need not even think. Now, a patient has undergone a cardiac, say, stenting. Can we do the MR? Within half an hour, we can do the MR. There is absolutely no issue. Cardiac stents are not contraindications. Sternal wires are not. Prosthetic valves are not. Okay, because today you have a lot of bioprosthetic valves which are coming in, which are no longer contraindications for MR. Now you should know what are the limitations of MR. Now there is a patient with trauma. I'll give you an example. There is a blunt abdominal trauma. The patient is bleeding. He is in shock. Now you want to do an MR. Please don't get an MR done. It's waste of time for two reasons. One, you cannot pick up the hyperacute blood. Suppose this patient has a hemoperitoneum, you will be missing out on hemoperitoneum because MR cannot pick up hyperacute bleed. It can still pick up acute, subacute, okay, or chronic. But when it comes to hyperacute bleed, MR is a poor modality to detect. Second, you're wasting time. MR will take at least 15-20 minutes. Though we use sequences which are faster, still it will take more than 10 minutes, 10 to 15 minutes. So there is no point in wasting time. Second, evaluation of calcification. Whenever there is a pancreatic calcification or pancreatic ductal calculi, please also ask for a CT because MR cannot pick up these calcifications or calculi. So that is why you have to get a CT also for these patients. Hyperacute bleed, CT. Blunt abdominal trauma, CT. Don't get an MR done. Now, what are the important pulse sequence parameters? Okay. Before that, I'll just go to the next slide. There are two sequences which you need to know and commonly used. What is T1 weighted sequence? What is a T2 weighted sequence? Okay. And for you, don't look at all this. Short TR, short TE, long TR, long T. It does not mean anything to the clinician. I'm telling you. Okay, it's waste of time. It is for the radiologist. And even there is no point in radiologist mentioning, oh, it's a long TR sequence, long TE sequence. What do the clinicians need? The clinicians need to know whether is it fat, is it blood, is it flowing blood, is it iron, is it soft tissue, and so on. Okay, so for that, we use these sequences, T1 weighted, T2 weighted. I'll show you the images also, how it looks. We'll go to that. The third sequence, which is important for you, is called as the inversion recovery sequence or STIR sequence, STIR. Okay, in STIR sequence, what we do, I'll show you first the T1 sequence. In T1 sequence, let's take this. This is the proton. RF will hit the proton. Now you know this. Patient is inside the magnet. Hydrogen is aligned along the magnet. Now you're hitting it with a radio frequency pulse. What do you mean by short TR? TR means repetition time. TE means echo time. Okay, or time to echo or time to repeat. Either way you can take. Now, I bombard this with a radio frequency pulse. Hydrogen flips. I stop my repetition time. Okay, then this comes back. I hit it. It flips. I take out the radio frequency. Then I allow very short time. This hydrogen has not come back. It has just come till here. I echo. I take the signal from it. So I hit the magnet, that is the proton, that is the repetition time. I stop it. Then it has come here. I take the signal. So it's a short repetition time and a short echo time. Why is it short? Because I have not allowed the hydrogen to come back to its normal. That is known as a T1 weighted sequence. Short repetition time, short echo time. Now, what is long TR? Now, I just don't hit this and take off. I hit this and hold it. My radio frequency keeps hitting the hydrogen proton, so it flips. And I don't take the signal like T1 when it is here. I allow the hydrogen to relax. It comes back. So there is a long duration which the hydrogen takes to come back. That is known as long echo time. So I bombard this longer and I allow the hydrogen to come back longer for a longer time. That is known as the echo. So that is long TE. Now, what is the difference between T1 and T2? In T1, the best way to diagnose T1 is whenever you do an abdomen, look at a fluid containing structure. Now, your gallbladder can have bile. Okay, the bile can have different signal intensities. So the best thing is look at CSF. If the CSF is black, it is T1. If the CSF is white, it is T2. Why is it white? Because I have allowed the hydrogen to come back for a long time. I have taken out more signal, so the water starts looking white. But when I take the echo when it is short, TE, the water looks black. So please look at CSF to know whether it is T1 weighted or T2 weighted. The simplest way to look at. I'll show you this. The third sequence is inversion recovery. Oh, wow, this is one more new term. Now, what is it? There is nothing great in this. Inversion recovery is what I do is now I hit the hydrogen proton with the radio frequency. So I reverse the hydrogen proton. So from this direction, I flip it 180 degrees. So once it is flipped 180 degrees, I allow say 100 milliseconds or 120 milliseconds for it to come back. Then I start the sequence. Then the fat gets suppressed. That is all inversion recovery is. Whenever you see suppression of fat, fat will look white on T1. I'll show you that. And if it starts looking black on the sequence, it is an inversion recovery sequence. Please remember only three things now you have to remember. T1 CSF, fluid is black. T2, fluid is white. Inversion recovery, fat is looking black. Fluid will look white. Clear?
Yeah, very clear.
Please, if you have a doubt, please ask me. I know that, see, for us, this may be the routine, but for you, okay, you should know because in the exams, once you put up an MR, if the fat is looking black, you know it's an inversion recovery sequence. Straight. Liver is all looking white, or you know there is some edema, or there is some tube. Now, what are the T1 weighted sequence? What looks white? Fat looks white. Stationary blood looks white. Please remember. There are only two things what you need to remember. Okay, remember three sequences, T1, T2, inversion recovery. Remember two things which look white on T1, that is fat, stationary blood. Now, things which look dark on T2, everything looks white on T2 because you have allowed a longer time for the protons to recover. But there are two things which look dark. Flowing blood, second is iron. Flowing blood, why does it look dark? Because the blood is flowing inside a blood vessel. It is at this point, point A. I would have given the radio frequency pulse at point A. By the time you give the second radio frequency pulse and take a sample or echo, this RBC would have moved from point A to point B. So it is no longer excited again. You have just excited it once. By the time you take the signal out of that, this would have moved. That is why flowing blood looks dark. Okay, don't get confused. Flowing blood, dark. Then anything which looks white, don't take it as calcium. On CT, calcium looks white, but here on MR, calcium looks black. Okay, cortical bone, if you see, looks black. The only thing which looks white is fat. Now, there is one more sequence. Now, I'm introducing the fourth sequence. Okay, I'm not boring you with more. remember 5 sequences for today. I think you know 50% of MR. I am not exaggerating. These are the only 5 sequences you need to know as a surgeon. But as a neurologist, it may be different. Then as a musculoskeletal radiologist, it may be different. But for a surgeon, you need to know 5 sequences. Now, what is this gradient echo sequence? Oh, this is new. T1, now I know. T2, I know. Inversion recovery, I know. What is gradient echo? Gradient echo is a very short acquisition sequence. Let's not get into the physics. But in gradient echo sequence, your blood starts looking white. On T1, it is black. T2, it is black because it's a flowing blood. Now, sir, you are saying that flowing blood should look black, but now on the gradient sequence, it is looking white. So in this, what I do is I change the black to white. That's all I do in the sequence. Using a pulse sequence, the flowing blood is looking black. I convert it to white. That's all I do. Gradient echo sequence, which we use regularly when we image, say, liver, pancreas, intestines. Now, what are the terminologies you use in MR? You use only 3 terminologies: hypointense, isointense, hyperintense when it comes to abdomen. What is hypointense? It is self-explanatory, right? Hypo is less. So it is black. It is less white than the liver. We'll take liver as the reference. Isointense, yeah, this is looking similar to the liver. There can be lesions within the liver which can look the same signal as the liver. Okay, so they are isointense. Hyperintense, hyper, they are white. Hypo is black, iso is same, hyper is white. So these are the 3 terminologies which you need to remember. Again, a recap: 4 sequences till now: T1, T2. What is the third one?
Stir.
Stir sequence. Excellent. And the fourth is
Gradient.
gradient.
Echo.
So we have got 4 sequences, 3 terminologies: hypointense, isointense, and hyperintense. Good. Now we go to the anatomy. Now let's take this. You will start answering now because you know the physics. Okay. So this first image is an axial acquisition of liver. Is it T1 or T2? Look at, this is the spine. Okay, I'll give you a clue. This is the spine. This is the cord. And you see a rim surrounding that. That is
T1, sir.
T1.
T1,
Excellent.
sir.
T1.
You got
Yeah.
it. Excellent.
Yes,
You got that. So what is this in the middle?
Aorta.
Aorta.
Aorta, right? Flowing blood is looking black.
Yeah.
And this is within the liver, again a vascular structure. What is that to the right of the aorta? What do you get?
Inferior vena cava.
Inferior vena cava. So this is the aorta. This is the crus of the diaphragm. Look at the difference between the signal. This is isointense, almost like liver. This is flowing blood. This is a T1 weighted sequence. And this is the liver. So now within the liver, you see this branch here. Okay, now the segmental anatomy also becomes very clear when you go from, say, top to bottom, or the superior surface, diaphragmatic surface of the liver. Then you go down to the segment 6. So superiorly, you have segments 8 and 7.
Yes.
Then posteriorly, you have 5 and
5 and 8.
5 and
5
8.
and 8. 6 and 7.
Then you have 6 and 7. Then superiorly on the left, you have segment 2.
2.
Then 3.
3.
So now you have the gallbladder fossa also, where you have segment 4.
4.
So here you have segment 8 of liver, you have segment 7 of liver, you have flowing blood, which is inferior vena cava. This is the left portal vein. Again, flowing blood is black in color, T1 weighted. Now, if you take this, this is the main portal where it is actually dividing. Then you have the segment 6 branch coming down. This is IVC, and this is what?
Gallbladder.
This is between the IVC and portal vein segment 1, right?
Yeah.
Caudate.
Caudate
So
lobe.
this, you see it as a tongue-like projection going anterior to the inferior vena cava, and it is posterior to the portal vein. So this is the caudate.
Right.
And this one is the falciform ligament here.
Falciform ligament.
You see this? So this is the one which again divides segment 4 from segment 2 and 3. So now if you want to do an extended hepatectomy, like you also take off the segment 4, and then you look at segment 2 and 3, and you can also calculate what is the volume of 2 and 3, what we call as future liver remnant, FLR. Right? So you can calculate the FLR both on MR and CT, but I personally feel it is better we do that on a CT because we will be more accurate. Now, so this is liver, and now let's look at the other structures which are close to it. What is this area? Now, black. What are the things which are black on T1 or T2? It is either cortical bone, flowing blood, or air. Now, why is air black? Now we look at this here, the lungs. The lungs are looking black. Now, why is the air black? Air is black because it does not contain enough number of hydrogen protons. That is all the explanation is. Air does not contain enough number of hydrogen protons. That is why it looks black on MR. Like CT. CT also, it looks black. MR, it looks black. Now, this is the stomach. Okay, this is the air within the stomach. This is the spleen. And this fat, what you see here, between the liver and the stomach is the gastrohepatic ligament. This is the gastrohepatic ligament. Now, why is gastrohepatic ligament white? Because
Fat.
it contains fat. This is T1 weighted. The moment you see white area, you know it is fat. It is between liver and stomach, so it has to be the gastrohepatic ligament. Similarly, this is spleen, this is stomach, and this area, fat is the
Splenic ligament.
ligament. Isn't it? It also contains fat, and then you have the tail of pancreas within the gastrosplenic ligament, coming down towards the spleen. Clear? Okay, now again a recap. Right lobe, left portal vein on these images. Okay, we have inferior vena cava, aorta, diaphragmatic crura, gastrohepatic ligament, stomach, gastrosplenic ligament, spleen. Is it clear?
Yeah. Very.
Now, let us look at the T2 weighted. Now, look at this. Look at this. This is the spinal cord. This is the vertebra. CSF is white. Okay, you see the CSF here, it is black. CSF here is white. So it is a what sequence?
T2 weighted.
Weighted sequence. Clear? Any doubts, please? You can always interrupt me.
Yes.
So that is a T2 weighted, and you see the flowing blood. Aorta is black. IVC is black. Part of the portal vein seen here is again black. So whether it is T1 weighted or a T2 weighted sequence, you always see the blood, the flowing blood as black.
Yeah.
Now, this is a T2, this is T2. There are no fluid containing structures here within the liver, here on the axial or the coronal. So basically it tells us there is no intrahepatic biliary dilatation because fluid containing tubular structures in the liver on MR are always intrahepatic biliary radicals.
Yeah.
Okay, so in this talk, let us not look at that. in the subsequent talks, no, we can probably choose a topic where we can speak on MRCP. Okay, that we will decide. Now let's and now some other structures here. Now you see this structure here. What is that?
Yes.
Pancreas. Excellent.
Pancreas.
So this is the stomach. Clear, because stomach has air and there is some air anteriorly. The patient is supine. The air is anterior. It is non-dependent, right? The air always rises up. There is some fluid within the stomach. Air is above that. Posterior to the stomach is the pancreas. So this is the uncinate process of pancreas. Now, if you look at a flow void there, where I am showing you, what is that structure? Flowing blood. SM?
SMA.
SMA will be to the left
Here,
of
SMV. SMV.
SMV. Okay, so this is SMV. This is the uncinate process, which is behind the SMV, like a hook-like projection. You can see this, it curves medially. So on table, when you open, just imagine you're seeing from above. Okay, you would have retracted the stomach. You will see the pancreas. Behind the neck of the pancreas, you see the superior mesenteric vein. Behind the superior mesenteric vein, you see the uncinate process of pancreas. And then you see a structure here, a dot here. This is superior mesenteric artery. Okay. Then behind that, in this image, you see a vascular structure crossing the aorta anteriorly, going into the IVC. This is IVC. This is aorta. So
Left
what
renal
is
vein.
left renal vein? Absolutely. Clear? Left renal vein, it is like third portion of the duodenum. It is always horizontal. And you can also have going behind the aorta, what you call as the retroaortic renal vein, but here it is going anterior. It is normal. This is the kidney, left kidney. And what is this white area inside the kidney? On T1, white
Pelvis.
should be, yes, it is the renal sinus fat. Okay, so the renal sinus fat, again, wherever there is fat, it looks white on T1. Clear? So this is the left renal vein, inferior vena cava, aorta, left kidney, renal sinus fat. This is the stomach. This is the pancreas. Superior mesenteric vein, superior mesenteric artery.
Radhesh, I just wanted to ask one question.
Yeah.
When you say the spatial images with the MR, will it give you the definition that is the plane between the superior mesenteric vein and the neck of the pancreas for us to, determine whether the tumor is resectable or not? Is that better with MR or CT?
See, I feel it is better with MR. Whenever you image pancreas and you have an uncinate or head of the pancreas lesion, which is now encasing the superior mesenteric vein. Now, it could be a total encasement, or it could be, say, 180 degrees or 90 degrees. I think MR picks it up better than CT.
Okay.
Because you have a difference in the signal intensity here. There, though you give contrast, the enhancement of the tumor and rest of the pancreas will almost be the same.
Same.
There is not much of a difference. But here you can use different sequences like T1, T2, and then you can use a contrast. You can use an inversion recovery sequence. You can use a diffusion weighted, again, to define the involvement of superior mesenteric vein.
All these different sequences, can you just do it by using programming the computer, or is there any physical activity that you need to do with the?
Not really, not really. Initially, we take time to standardize these protocols. And once these protocols are standardized, we save these protocols under specific heads. Now we want a triphasic liver. It is stored under triphasic liver. All the technicians need to do is just take the sequences and then start running it.
Okay.
Now, What sequence is this?
T2.
T2.
No, blood is bright. T2, you're correct. Gradient, because the blood, aorta is white, IVC is white, hepatic veins are white, portal is white, everything is white. So this is a gradient echo
Gradient
sequence.
echo sequence. Yeah.
Echo sequence. Now, when do we do this? Now, is there a necessity to do this? Sometimes what happens if the patient has renal failure, we cannot do a CT. Okay, we have to do an MR in these patients. These gradient echo sequences come in very handy whenever there is a thrombus. So to see the filling defects better, we do a gradient echo sequence. Now you definitely know, like you are clinically you're saying, no, this patient does have portal venous thrombosis, but this patient is also in renal failure. Now we need to know, is there a tumor thrombus extending from the hepatic veins or the portal veins into the IVC, or has it come down into the SMV? So in such cases, we do this gradient echo sequence. These are very fast sequences. To acquire the whole liver, we need around 12 seconds. One breath hold, the whole liver can be imaged. So this, we actually do it as a routine. Now you see the difference.
Radesh, it's a very stupid question, but I just asked, I thought I'll ask, what is the so necessity for breath hold and what does it actually do for you?
Okay, so see, in MR, the movement, the motion is, to stop the motion is extremely important. Though we have sequences where we can do with free breathing, we put what you call as the respiratory gating to the patient. So this magnet is so intelligent, it picks up when the movement is relatively still and it takes an image. But these sequences, gradient echo sequences, the patient has to just hold the breath. So the movement is not there.
There at all. Okay.
So that is why I think it's so important on MR, because especially on the 3 Tesla magnets, if there is a slightest movement, even the ascitic fluid for that matter, looks very nice on a 1.5 T, but on a 3 Tesla, you see there is shading. It looks dark. Because of the movement, there is so much of noise. This noise gives that black color to the ascitic fluid. So now you see the difference here. I'll just show you. I'll go back. You see this pancreas so beautifully seen here as a grayish structure. This is black SMV, and then you see the pancreas. Now look at the gradient. See this? This is pancreas. See the signal, so different it is. And this is the kidney. And then you see the blood vessels here. You see the supramesenteric artery taking off from the aorta. And then this is a vein there, portal vein. You can see the portal vein going. This is the splenic vein. This is the portal vein. So they're looking white. And then the stomach fluid is looking white. CSF is looking white. It is more like a T2 weighted sequence, but the blood vessels are bright.
Okay.
Now, this is a coronal section. Okay, and again, what sequence is this? Look at the liver. Look at this. You see the hepatic vein here?
White. So again,
it's a gradient sequence.
Gradient echo. Yeah.
Gradient echo. And one more small clue I'll give you to make things even more easier. Any viscera you take kidneys, for example, here, or the spleen you take, look at the border. How is it? It is black.
Fat.
Absolute. This is called as a chemical shift artifact. Whenever there is water and fat, you always get at the junction a dark line or a black line, which tells you it is a gradient echo sequence. So if you have a doubt about the vessels, look at the margins. Look at the spleen. You see this? There's a black line here. This is a fat. This is the splenic margin. So you see it as a black line. You take liver, you take fat, you see this, the capsule looks so dark. So that is how you say it is a gradient echo sequence. Next. How much more time we have, Ravi? Can we go on?
Yeah, we have another 10-15 minutes easily.
15 minutes. Okay. So we'll try to finish this part at least. Now, next, you will ask for a triphasic liver. Or you say there is a patient has a pancreatic neoplasm. Do MR with contrast. So you should know what contrast we use. For CT, what is the contrast we use?
Gadolinium.
No, for
No, no.
CT. For CT,
Iodinated.
Iodinized.
iodinated contrast. Excellent. So we have to use iodinated contrast because this iodine attenuates the X-ray beams and it starts looking white when it is inside the vessel. Similarly, for MR, you cannot use iodine, so you use gadolinium. What is gadolinium? Anyone? What substance is it? Gadolinium is a paramagnetic substance. Okay. What does paramagnetic substances do? Paramagnetic substances reduce T1 of the tissue. So let's take example. How does fat look like on T1?
Black. Sorry, white.
White. So now that fat has X value for it to look white. Now I am reducing that value further by using a paramagnetic substance, which is gadolinium. So how does gadolinium look on MR? Like
Whiter.
iodine. White. Absolutely. It looks white. Because on MR, when we use gadolinium, which is a paramagnetic substance, it reduces the T1. That is why once the T1 is reduced, the whole thing starts looking white. Let it be the aorta, portal vein, hepatic vein, IVC, or any vein for that matter, or any vessel starts looking white on contrast. That is why you use gadolinium. You do, say, an arterial phase, you do a venous, early venous phase, you do a late venous phase and a delayed phase to look at the enhancement of the tumor or an infective focus. It could be in the liver, spleen, pancreas, or even the lymph nodes. Now, for liver, we use two substances. One is, which is hepatobiliary, which is, we don't have this manganese contrast. It is not available in India. So we do a compromise study. We use a combination of extracellular and intracellular or a hepatobiliary agent, what is known as gadolinium bopta. Okay, gadolinium bopta, it is by Bracco. It is available in India. So we use for all the hepatic studies, we use gadolinium bopta, which is around 15% to 20% excretion by the liver. That is why we use this hepatobiliary agent whenever we image liver. Gadolinium is not hepatobiliary. Gadodiamide, what we use, just goes into the extracellular compartment. But this gadobenate dimeglomin is gadolinium bopta, which is excreted by the liver, which is around 15 to 20%. Now, let's go to a few conditions. Okay, so this is, let's look at hemangioma. I would like to just give, see, in all my talks, I believe you can get anything on Google today. And you can get anything from people like now in the rounds, Ravi is there. You ask him, he will tell you. Okay, but what we all like is we speak our experience out. Okay, that is very, very important because we know where we have made a mistake, where we don't want the same mistake to be done by you people. So the take-home messages are extremely important. You have come here not to learn about MR, but here you have come here to take away 5, 6 good things what you need and sleep over it tonight. So now, cavernous hemangioma. You all know that, yeah, you see an echogenic focus or a mass on the ultrasound. And how does it look on MR? So in MR, when we do a dynamic contrast study, you see this. This is the contrast within the aorta here.
Yeah.
The veins are not opacified yet. So this is the arterial phase.
phase.
And then you start seeing some enhancement within the lesion, very, very minimal along the periphery. This is the next phase. This is, you see the IVC now has come in. Hepatic veins, you are already seeing them. The enhancement has increased. Now, further delay, you see more enhancement. And this is after 5 to 6 minutes, you see just a small streak which is not enhanced. The whole lesion has filled. And further, almost the entire lesion has filled. So what is the pattern of filling? What do you call this? Whenever you see an image, CT or an MR, if you see this pattern of filling from the periphery towards the center, it is called centripetal filling. So for a hemangioma, this centripetal filling is you can say sine qua non of diagnosis. You do not get it in hepatic adenomas. You do not get it in FNH. You will not get it in hepatomas. You will not get it in metastasis. So if you see a centripetal fill-in of contrast and slowly the lesion becoming iso-dense with that of the liver or iso-intense with that of the liver, this is hemangioma. Now, we do one more sequence. This is a multi-echo sequence. Now, what is a multi-echo sequence? See, now you know T1, I sample early. T2, I sample late. Now, in a multi-echo sequence, I keep on sampling 20 milliseconds, 50 milliseconds, 60, 80, 90, 120, 200, 380. So that way I keep on taking the echoes at different time intervals. In a hemangioma, what happens? This is at echo time 20. This is at echo time 380. So how is it looking? It is a mesenchymal lesion. These mesenchymal lesions always look very bright as you take samples later. At 20, it is white. At 380, it is really bright. Classical for hemangioma. Two things, take home message, centripetal fill-in of contrast, and second is becoming brighter on delayed echoes, multi-echo. Now, I'll skip this. To understand better, I'll go for one more slide here. Okay. Now, this is a case of metastasis. Multiple lesions in the liver, varying sizes. This is at echo 22 milliseconds. This is at 380 milliseconds. What has happened to the lesions? Are they bright? Not really, right?
Not really.
22, it is bright. 380, it has become darker. Actually, as compared to 22 milliseconds, at 380 milliseconds, it is darker. But look at hemangioma. In contrast to that, see this. It's really bright at 380 milliseconds. So that is how you differentiate based on multi-echo hemangioma from metastasis. Now, let's go to one more example, which is an excellent differentiator. Post-contrast images, I've just put one slide for you. Now here, this is liver hemangioma, which is becoming bright. This is metastasis where the lesion is becoming dark. Now, based on the capsular enhancement, how do you differentiate metastasis from hepatoma? Let's take one example. This is hepatoma. You see still the contrast is there in the aorta, and delayed section show a beautiful capsule surrounding the lesion. You see this?
Yeah.
capsule surrounding the lesion. There's also a small satellite. It is not a single lesion. There are two lesions here. And this is classical for hepatoma, where you see a capsular enhancement. And in metastasis, the reverse happens. The capsule gets washed out. It becomes hypointense. So it is this is basically a peripheral washout. We call it as a peripheral washout sign, where the periphery washes out in metastasis. So you see it as a hypointense rim, but on hepatoma, you see the enhancing capsule. So to differentiate hemangioma, you do a multi-echo from metastasis. To differentiate hepatoma from metastasis, again, you can do a washout phase. You slightly delay the phase. The capsule enhances in hepatoma. There is a washout in metastasis. Is it clear?
Yeah.
All this you can easily pick up when you put up the MR. Now, I will show you just two more. I think we will probably conclude, which is very interesting. I told you I'll show you a cine image. The advantage of MR is cine. So this was a patient, echo was done. They said it is a right atrial myxoma. Okay, nothing wrong in the diagnosis because the cardiologist saw the right atrium. He saw a mass in the right atrium. So this patient was referred to us for a cardiac MR. When we did a contrast study, we found this. I'll just stop there. You see, this whole thing is the tumor. The liver outlines are nodular, they're cirrhotic.
Yeah.
This is hepatoma, and you see the thrombus inside the IVC.
IVC, yeah.
So this thrombus is what you see here, which is going into the RA. And then you can always run it. So this is firmly stuck. It is not loosely pulsatile. This is the left ventricle. This is the aorta. This is the annulus of the aorta aortic valve. And this is the IVC opening into the right atrium. So actually this was a case of hepatocellular carcinoma
with tumor thrombus in the
IVC going into the right atrium. Okay, so you will get, if Ravi is the examiner and if you pick this up, you'll get a distinction. What, Ravi?
Definitely.
Definitely, yeah. And one last thing here, I was talking to you about diffusion weighted sequence. This is the fifth sequence. We spoke of T1, spoke of T2, spoke of inversion recovery, gradient echo sequence, and last is diffusion weighted. Now, where diffusion weighted helps us, I'll show you. So this is a patient who came to us. When we did the contrast study, you see the contrast is there. Gadolinium is there in the aorta. That is why it is looking white. See IVC. Some vessels within the liver. This is the IVC. Now you see the right lobe, left lobe. Volume is small. You know it is a cirrhotic liver. But I don't see anything else. Maybe this is an artifact. There is ascites. Beyond that, I don't see. I see collaterals, but I don't see a tumor. Now, I do a diffusion weighted sequence. In diffusion weighted sequence, now what is diffusion weighted sequence? Diffusion weighted sequence is evaluating the restriction to the hydrogen protons, meaning if you take CSF, CSF is liquid. So the hydrogen protons in the CSF can move wherever they want to. There is a randomized movement of the hydrogen protons because there is only fluid, there is no solid to prevent the movement of hydrogen protons. But in a solid tumor, the hydrogen proton movements are restricted. Now, the moment there is restricted movement to the hydrogen protons, we use what a sequence called diffusion weighted sequence, which picks up this restriction of the movement of hydrogen protons within the tumor. The moment there is restriction to the movement, now why is there a restriction to the movement? Anyone in a tumor?
Fibrosis.
It could be fibrosis. It could be
More
tumor cells itself. It could be rapidly multiplying tumor
Tumor
where
cells.
the cellularity is very high. The moment there is increased cellularity, these hydrogen protons get very little space to move around between the tumor cells. And this causes restriction to the movement of hydrogen protons, which we use the capitalize on that and do a diffusion weighted sequence so the tumor stands out. You see, this is white, the normal liver is dark. There is one more small lesion here. I think this is also a lesion what we saw in the previous.
So you could have missed this if you had just done an ordinary sequence.
Absolutely. That is all I wanted to convey. So you have to tell your radiologist, you want a diffusion weighted sequence. Okay. And if again you want to score a distinction, you tell the radiologist, I want a B value of 800. Okay. He will understand. B value is the value what you assign for the for calculating the restricted diffusion. You have B0, B50, B100, B800. For the liver, the best B value is 800. For the prostate, we use a B value of 2000. But for liver, it is 800. So then you start seeing the lesion white. Oh, you know, the entire left lobe is there. You also have segment 6 having the lesion. So this is a multicentric hepatoma. Okay, and what is this sequence? It looks so bad. It is exactly the reverse of diffusion, what we call as apparent diffusion coefficient. We can in fact measure the value here. Based on the value also, we can say it is more cellular, it is less cellular. Okay, but remember only diffusion. T1, T2, inversion recovery, gradient sequence, and diffusion weighted sequence. If you don't see a lesion on T1 or T2, always do diffusion. In fact, you have to do diffusion. Okay.
Would this lesion have been picked up by an ultrasound?
Depends on the echogenicity. Again, if it is isoechoic to the right lobe of the liver, they would have missed it. Ultrasound is not actually a very good modality in fact,
for liver anyway.
For liver. So best is MR because you have all sequences which come to your rescue.
Yeah.
So these are the things what I thought I think I'll share. So these are all fine. We can always have one more class where we can look at.
Yeah.
Okay. So let's open it up for, if there is time, we can open it up for discussion. Okay. Anyone please ask.
Anyone has any doubts or any clarifications?
Sir, in the stir, I mean inversion, fat will be black alone.
Fat is black.
Sir, even in T2 it is black alone.
T2 it is not black. ಈಗ T2 ನೋಡಿದ್ರೆ ಈಗ I'll show you. ಇದರಲ್ಲಿ ನೋಡೋಣ ಬೇಕಾದ್ರೆ. Okay, so we'll take this example. ಈಗ ಇದು T2 weighted ಅಲ್ಲ? You see the spine, you see the cord here, you see the CSF. This is a T2 weighted sequence. And this is the fat, subcutaneous fat. This is the fat, gastrohepatic or gastrosplenic ligament. Okay, now you see this sequence. This is the fat. Fat is black. So is it stir?
Yes.
It is not stir because stir is a T2 weighted. CSF is still black. So this is a T1 weighted fat sat sequence. Okay. So that is why I didn't want to confuse you because you can suppress fat in different ways. You can have a stir sequence, then you can have a T1 weighted fat sat sequence where you sat means saturate the fat. So you make the fat look black because the contrast stands out. Okay.
Yes. Any other questions?
No, sir.
So actually speaking, I think your talk was absolutely so clear. I don't think anyone has had any questions or doubts. I have see the no the what actually there is a very good saying in English. The eyes do not see what the mind doesn't know. So that is the advantage of Radhesh. He knows what he is looking for and goes after it. That is why the radiologist is extremely important in picking up ordinary lesions which stare at you. Anyone can pick up. So if you, for example, I think many people would have missed the tumor in the background of a cirrhotic liver. I think if you didn't do the fifth sequence, the fifth, you would have definitely missed it. So that is why it is important to know what investigations and what sequences to do in what situations. So that is why I think it's important for you to give the clinical information to the radiologist so that they can then go after whatever you are looking for and then give you the answers. So I think I have to thank Radhesh for, I think I don't know about my students, but I learned an awful lot from this. Everything that doubts that were there has been very well clarified and very well, doubts have been cleared. And I thank you for an excellent lecture. I didn't know that 1 hour has flown by without even, I didn't even yawn once. So I think it is excellent class. And I thank you on behalf of all our students. And we'll have another class about MRCP and maybe other,
I think MRCP will have.
and breast mammogram. I think breast also. I think
Yeah.
it may be MR mammogram, so it may help us.
Sure.
So I think we'll have that. So thank you so much, Radhesh.
Two things we will do. One is, I think, as you said, MRCP we will do. And one more, I think, some bowel lesions we'll look at.
Yeah.
I think that's so important.
Yeah.
Look at MRCP also, Ravi, you can probably next class, no?
Next, yeah,
Whenever.
we can do
And
that.
one thing I want to tell all your postgraduates, Ravi, if they are free, please feel free to walk in any time to our center. Okay, you
Thank-
can always, we will give you a computer. We are there to help you out to look at the cases. All the reports we have stored, so you can look at the reports. Okay, and feel free. Okay, so it's always, once you come, we'll also learn. It is vested interest because you teach us the clinical part of it. We'll teach you radiology.
Thank you so much, Radhesh. It was
Thank you.
really an excellent lecture, and we will look forward to more of the same from you. Good night. Thank you very
Good
much.
night. Thanks. Thank you all.
Thank you.
Thank you, sir. Thank you, sir.
Thank you.